If you experience chronic pain, you know how very debilitating that can be in many ways, especially if it's chronic low back pain, because so much movement engages that part of the body. Welcome to Mindfulness Voyage. My name is Ted Meissner, and today we're going to be reviewing a paper with several co-authors that explored chronic low back pain, mindfulness, and cognitive behavioral therapy. Please do remember to subscribe to this podcast if you're getting something out of these conversations, as it helps other people to find this podcast. Thanks so much, and let's begin. Hi, everyone, and today we have a special panel discussion about new research. So I'd like to invite each of you to just say a little bit about who you are and where you are. Alexandra, perhaps we can start with you.
Sure, Alexandra Zgierska. I'm a physician specializing in family medicine and addiction medicine, and a researcher with my research primarily focused on addiction and pain, improving outcomes in these conditions. And I'm at Penn State College of Medicine.
Thank you and welcome. Nalini, how about you?
I'm Nalini Segal. I'm a physician at University of Wisconsin-Madison in the Department of Orthopedics and Rehabilitation. I am a physical medicine and rehab trained specialist, focusing all my work and expertise on chronic pain management. I treat patients with chronic pain with both interventional and non-interventional techniques.
Thank you. Welcome to the podcast. And Shaila, how about you?
I'm a clinical psychologist at the University of Wisconsin in Madison that specializes in innovative approaches to managing chronic pain. I explore treatment through cognitive behavioral therapy, mindfulness meditation, acceptance and commitment therapy. And it's been an honor to be part of this project as one of the clinicians delivering some of the interventions to pain patients.
Wonderful. And thank you and welcome all of you to this podcast. And thank you so much for making time for us to have this discussion. And I'm curious from each of your perspectives, what is it that brought you to work on this particular project? I'm a little bit curious about how this came about. And Shaila, maybe we can start with you on what got you involved with this particular research.
I remember the day very clearly when Alexandra called me and said, I have this idea for a research study. And we met along with my coworker, Janice Ingalls. And in particular, there is an epidemic of chronic pain in our country, that over 100 million people have chronic pain. And we know that opioids don't work. And although we have a lot of advances in modern medicine, it's still leaving patients lacking in terms of reducing their pain, but also the level of overall suffering. And so this project of comparing cognitive behavioral therapy to mindfulness meditation, I think is really such a unique experience. And we've just learned so much from the research of what helps patients not only reduce their pain, but also improve quality of life and functioning and lowering suffering.
Thank you for that. And such an excellent point that the distress is more than just the physical pain, that there's other stuff to it as well. Nalini, how about for you? What got you involved in this particular research?
Well, I had been working with Alexandra, and I had invited Alexandra for our fellows research day, and she presented her pilot study on mindfulness meditation in opioid-treated low back pain patients. And following that, I still remember how she came into my office and we sat down and we discussed about the PCORI project and what we are going to do it. So that was the initial beginning. And she was kind and generous enough to keep me involved in this project, but she's the main person behind this. She's the rock that got this moving for us. So I would give all the credit to Alexandra.
Thank you, Nalini. And Alexandra, how about for you? What was that gem of an idea that made you want to bring people together for this research?
So the answer can be very long, but I'll try to keep it short. And first, I'll feel like I'm going to wipe my tears because thank you, Nalini and Shaila. Yes, it's been wonderful to work together. And I didn't remember all the details. So now I'm reminded about those. As a primary care clinician, I've seen so many patients coming to my office with chronic pain. So many people, and it all started about 15 years ago. So the height of the opioid epidemic, so many people affected by opioids, but later also affected by the changing landscape of opioid prescribing when the opioids were sometimes withheld, sometimes abruptly discontinued, with a lot of additional suffering introduced through that and a lot of anxiety. So I was very interested in this aspect. How can we help patients? And as a primary care clinician, working closely with Shaila and also with Nalini, I'm quite well aware of our limitations, what we can offer through traditional approaches. So pain medications, procedures, they all are targeting very specific mechanisms, let's say neurotransmitters or receptors, and they can have impact, but it's usually rather short-lived and not expanding and extending to all aspects of patients' lives. While chronic pain affects kind of everything. I cannot think about what is not affected by chronic pain. And so, again, as a primary care clinician, I was looking at what can I do to really help holistically through all the lenses that I see people struggling with. And I settled on psychological treatments. So as a researcher, then I thought, what is there? What's the uncharted territory? Because of course, as a researcher, we want to study something that nobody else studied. That's the best area. And yet what is already in use, what holds promise. So that's how the mindfulness meditation came in place. And finally, there was a selfish component here, or individually focused. Life as of a clinician, scientist, wife, mother with small kids at home, it was pretty busy. So how do I personally introduce some wellness into my life? So that personal perspective was, if I study mindfulness, that will force me to work with it more closely and introduce it into my life. So these were like this multi-pronged elements. On top of that, serendipity. Like there were people along the way who I met who helped me hone down on this particular approach, on this therapy, on the study design, etc. So that's the short version of the story.
And there's so much there, so many rich dimensions to it, that there are interventions for chronic pain, and there are some limitations to those, and what might be things that are alternatives to those treatments, and especially those that may be as helpful, and in some ways more broadly helpful, of more than just the chronic pain itself, but other aspects to that. As you're saying, it's more than just one thing, it touches a lot of stuff. So I'm wondering if, Alexandra, we can stay with you for a bit on this. Tell us about the study itself. What did it do? What was the structure of the study?
So we designed the study, and I'll start with this principle and concept because it's been overarching throughout, through the very end, through the publication. We started by working with our patients, our colleagues, clinicians, and former participants from the pilot study to make sure that what we do is not only scientifically sound, because that's what we can take care of, but also that it's meaningful to patients, not offensive to patients, because sometimes, and I'll give an example later on, sometimes we don't even understand that we might be saying something that is not just acceptable to patients or not aligned with their needs, preferences, and ideas. So we worked with, we call it stakeholders, but I will call partners throughout the study. We wanted to make sure that everybody has a chance to get treatment. So one can look at it as a weakness of our project because we do not have do nothing control group. So we deliberately selected this design to make sure that we have a chance to offer treatment to everyone. And we did. So that's why two separate arms of the study. We selected mindfulness, and I explained why, many reasons. And we selected CBT, cognitive behavioral therapy, because that's considered standard of care. However, doesn't mean it's covered. So it's still underutilized, understudied. So the extra benefit was to study CBT for chronic pain. Neither of these therapies has been well studied in patients who are treated with opioids. So that was another opportunity for us to really bring new information to the science. But then we worked again with our partners to make sure what we do is useful, meaningful, and acceptable to patients. So one example here, how our partners influenced us, was we as a team, we worked pretty hard to come up with the patient participant facing name of the study. And we had plenty of possible options, some with really great acronyms. So some of our co-investigators and staff were more prolific than others, but on the research side of things, favorite was healthy minds, healthy backs. Catchy, brief, down to the point, so we thought it was great. So the only downside was our partners just killed it. All of them, they didn't like it. So based on and they had reasons why it triggered so many negative, somehow connotations that we wouldn't have never thought about on our own. So the name of the study that we settled on with our partners' input was Strategies to Assist with Management of Pain, or STAMP study.
Yeah.
Kudos to Postal Service as well.
Yeah, and there's so much to that. This approach from, not surprisingly, from people within healthcare, that those of us who work in this territory are here to help people. We want to make a difference. And seeing research that enables everyone who participates to get an intervention, and one that has a history of helping people, in this case with chronic low back pain, while also furthering research, because as you've said, not a great deal of research out there around mindfulness, CBT, opioid use. All of that is fairly untapped territory. So a lot to this, but I also want to hear from the others. Shaila, how about for you, just in the crafting of this study, what were some of the things that you were particularly interested in seeing happen or wanted to have included in that?
I was involved in the pilot study and helping craft the mindfulness meditation intervention. And then we had input from some of the other stakeholders to refine that curriculum design. And then we had a wonderful curriculum of cognitive behavioral therapy. And I primarily delivered the cognitive behavioral therapy, but then provided backup for mindfulness meditation. So to answer your question, I think it was really fascinating to see patients with chronic low back pain who are on opioids respond to both interventions. Alexandra can speak to some of the differences we found, but in as little as a week or two, we were seeing benefits. It's always so inspiring to see patients self-choose tapering down off of medications like opioids. It's inspiring to see patients starting to really activate their mobility and walk longer, and more engagement in their lives. When I think of the mindfulness intervention, we saw patients starting to notice more of the life around them, starting to function better, starting to feel more like themselves, even if the pain was there. So we saw an enhancement of coping strategies with both interventions. And I think that's some of the best work you can do. And, my hope for this research, it can really speak to the importance of these interventions, the coverage of these interventions by insurance companies, and they can be more widely distributed.
Yeah. Thank you so much for that. And lots of things I want to follow up with on all of that. Nalini, how about for you? What were some of the things that you were most pleased about got included in how this research was structured?
From my point of view, I'm as I said, physical medicine rehab physician. So function was very important for me because that's what keeps the patients happy and healthy. And most of the studies that we look at, we not only look at the majority of the times reduction in pain. To incorporate function and get them moving, get them active was important for me. And this study incorporated the objective measures for assessing how did the function change over time with these treatments.
And that's a very important part of it, and something to share for those who are watching or listening to this is self-report has some limitations. If someone has gone through an intervention, invested the time and the dedication to it, that tends to have an effect on the outcomes, at least our perception of the outcomes. And Nalini, what you're sharing here is it's more than that. It's also what are we seeing from the outside, and not just a, gosh, I put in this all this time, I should see something. It's like, no, you actually measured very material changes to
Exactly.
functionality. Yeah, wonderful. So I also, one of the things I wanted to come back to, Shala, that you mentioned around coverage. And this is one of the things I hope grows as time goes on, is that not all interventions are covered by insurers. And there are some difficulties sometimes in having things like mindfulness interventions tend not to be. We don't see much health coverage for things like MBSR or MBCT or other kinds of interventions, but we do for things like cognitive behavioral therapy, for example. So I'm wondering if you had any particular hopes about what might occur, especially in terms of coverage. And in fact, any can join in, but maybe, Shyla, we can start with you on that.
And I think it's a call to action for insurance companies to cover MBSR or mindfulness-based cognitive therapy for pretty much any person, but especially for chronic pain, because I think if you track people who go through these programs, it actually saves insurance money in terms of there are less ER visits or less medications to provide. And there's probably also a healthier overall life as well. So that is the hope from this research, that there can be more systemic change, not only at the insurance level, but also providers to prescribe this to people suffering from back pain or just pain in general.
Yeah. And this is something that has come up in many of these podcast interviews, and I post regularly about this, that if mindfulness interventions are non-inferior, let's use that terminology, to treatment as usual, then perhaps it should no longer be put in amongst the alternative, but actually, if it works, we call it medicine. And it can be helpful in this way. Covering it actually, as you've said again and again in research, saves costs. So I'm wondering, Nalini or Alexandra, if either of you have any thoughts that you'd like to put in on this, please join in.
I think from my perspective, one is doing not only increase the awareness amongst physicians, because sitting in the pain clinic, I see, and I'm training young physicians about how to manage pain. And an important component for me is any patient who's walking into the pain clinic, 80% of them or 70% of them have depression and anxiety as comorbidities. And to ignore those and consider that we can manage them with injections or medications or surgeries will not help. So it's really important to understand and incorporate that every patient that goes through the pain clinic or through a physician's office should have this treatment incorporated as a total approach to managing pain. It's just not one thing, but it's the whole body or a whole person approach. So that's one. And then my second thought is there's a shortage of physicians or clinicians who can provide this kind of treatment. And is there a better way to encourage young students to go into psychology and help with more chronic pain management? So we have more of a psychologist in our clinic, and Shaila can speak well to it, how little we have of their availability, and we really want more of Shaila's at this time. I wish we had more of those. And plus the reimbursement. I think the big factor is how well are these services being reimbursed? Because if they are not reimbursed well, we cannot expect that young students or young clinicians will come and take care of this challenging patient population. So there are a number of reasons where we feel that if we can address those issues, we might improve care.
Adding into exactly what you said, and agree with that completely, is the need to recognize that mindfulness is a different discipline than therapy interventions, that one may be trained as a CBT professional and may not have the background in trauma-sensitive mindfulness, for example, or ongoing continuing education about mindfulness, and know the latest and greatest of why we do what we do and how to ensure the participant well-being with those. But currently, that's not how it is.
This is where some other exciting research by our colleagues, like Eric Garland, who is one of the investigators on our project, comes in, because he studied very brief mindfulness interventions in this very population of patients. And even the single time, one time, brief intervention delivered by not a person who is certified mindfulness therapist or provider, it still helped. It still made a difference. So the study that we did, it was 16 hours of in-session training. It's a lot of time commitment, a lot of effort for patients, our participants, but also for therapists. So one of my hopes is what we publish is just a tiny fragment of the data we have. And this was the most important part of the data, because that's kind of at the outset what we said we'll do. Now we did it. And it seems we see clearly that both mindfulness and CBT are helpful. We have data to do, we call it cost benefit analysis or economic analysis. We haven't done it yet, so that's somewhere out there looking for funding to do this analysis. But we also have over 1,000 of brief interviews with our participants at the beginning of the study, but also after they were when they were completing the study. And we asked them, what was helpful? What was not helpful? Like, what do you view? So it's been quite interesting, and this is maybe a preview of what hopefully will come in the future. There were about, I believe, 22 techniques identified, like specific practices from the mindfulness sphere, and more or less similar number from CBT exercises that people listed as their most effective strategies to manage their back pain. So vast majority of all things that they viewed, and this could be anything, medication, physical therapy, anything under the sun, majority of those, so let's say 70% or so, they were mindfulness or CBT study taught techniques, which I view as just unbelievable that people, but what it also means, maybe we can reduce those 16 hours to those most useful components. Maybe the training could be much shorter, which of course would require additional research to see whether it's working. But the hope would be that the training, that the interventions can be more accessible if they are shortened, which means more providers can deliver it, et cetera, et cetera.
This is one of the exciting things about research like this, is there's quite a large field of data, and that this research, this publication, is about an aspect of that, but there's much more to come. And it also brings up the challenge of doing research is funding to do so. For example, that cost benefit analysis based on previous kinds of research like that, and hopefully Eric will come on to talk about that work, and you all will come back to talk about when that data is able to be published. there's so much more to learn from this.
Yep.
And so I'm excited to hear, actually I'd like to hear from each of you about, with the results coming from this, what was maybe just one or two things that were most encouraging or interesting to you about these results? Nalini, maybe we can start with you on this one.
Yeah, what I found surprising was, one is that an intervention like this, both CBT and mindfulness, not only decreased pain, but they also improved their quality of life and function. And surprising that patients were able to decrease opioid use, and the effects were sustained over time. That was to me very surprising, because treatments that we have, I look at the durability of effect and it's not that long lasting. So that, and I put in a lot of effort to minimize or reduce opioid use in my population and find alternative ways to manage pain. So I was excited to see the results, because this again reinforces my thought process, and that yes, I should, in every patient should be getting CBT or mindfulness or some kind of behavioral treatments to manage stress, improve pain coping skills, and decrease their all pain overall perception.
Because that's all related. It all works together. Shaila, how about for you? What are some of the interesting things in the results that make you think about other future research, or was unexpected for you?
Yeah, I think it really speaks to the need for additional funding for Alexandra to continue her line of research with that large data set. So, and I want to piggyback on something she mentioned in terms of the qualitative interviews and what patients found helpful, because people listening to this, they may say, I don't have that kind of treatment available to me, or we don't have it in our facility, we can't prescribe it. And I think a little bit of practice can really be helpful. So, from a mindfulness perspective, some of the key practices were, before patients would take their medications, they practiced a couple minutes of mindfulness. We did a lot of practice with the body scan, just scanning the body, noticing sensations, and trying not to get hooked by that pain sensation, but bringing your mind back to scanning. Another really seminal practice is just mindful focus on breath. And so I just really encourage people to, there are wonderful YouTube videos or maybe other podcasts that have some mindfulness, or books, or recordings, to find some way of engaging with mindfulness. And I think from the cognitive behavioral perspective, and Alexandra, you probably could speak to the actual practices and skills patients found helpful, but things like pacing your level of activity. The one practice that really stands out for me is patients doing one pleasant activity a week. And you would think one thing, that's nothing, but it actually, they look forward to it. It brought them a lot of positive emotion. They were increasing their social connectedness. They had to get out of the house oftentimes. So again, that's that functioning mobility. And over the course of the study, the 8 weeks, they started to do better as a result of that one simple practice. So I think there are, I think, some really kernels of information that could help people instantly while seeking out maybe a more formal program to go through.
Yeah, and this brings up the idea of an initial taster of what may be helpful right now, a little bit, just sticking your toe in the water, and then longer term to sustain those efforts. Nalini, as you were saying, how do we ensure that there's long-term effects, which is a different thing from, I took a medication once, yeah, but are you going to keep that up, or are there other ways that we can help you that you can do on your own? Alexandra, how about for you? What were some of the interesting findings for you in this, or surprises?
So when we started the study, we hypothesized that mindfulness will outperform CBT. But as the time was passing, I couldn't it was hard for me to even root for it because that would mean that one therapy is better than the other. Well, in fact, we heard from patients and we saw in real life that both can target thought processes and how we relate to pain in a different way, but both can be useful. So what we found was, on one hand, a little disappointing, one would think, because it didn't document or didn't confirm what we hypothesized to begin, but it in fact showed that both are working. And we had this extra analysis, so-called non-inferiority analysis, to show that one is not worse than the other, which we documented, which in the regular human language, it means they were both the same in terms of their effectiveness. So our additional work will look at, can we identify who might be benefiting more from mindfulness versus from CBT? There was some inkling for some very discrete traits and features in our, like, who might do better, but in fact, they were so slight. It comes down to what people have access to, but also what they would like to do. Because in some, it's to me similar to like playing the instrument. If you decide to play the instrument, some people will love violin, some flute, and there's nothing wrong with either one, and it's completely personal preference. That being said, the more you practice with your instrument, the better one gets. So yes, single practice, single exercise can produce a sound. But if you keep practicing, and especially if you have good teacher or a teacher, you can get better faster and hopefully get even better results. So we did see that people who continued on, and I don't know why some people continued on versus some didn't. Like, that's one of the other questions that we have. Those who continued on, they seem to do better.
And thank you for that that simile of musical instruments. I have two flutes behind my screen over there and two more on the on the ground there. So yes.
Do you also have a violin?
I don't.
See?
But I
That's the
should. My
point.
grandfather was a violinist, so that's in there too. For those of you who play violin or other instruments, you're welcome to that party too. And I think to wrap up our conversation for today, wanting to be respectful of your time, what I'd like to do is ask each of you a last question about what are some of your hopes of outcomes from this research, or next steps, or what you'd like to see in the field of pain management, therapy, or mindfulness? Nalini, let's start with you in this one.
What would I like to see from future research on this topic? Well, I'd like to see if we can, because as Alexandra mentioned, and we saw in this study, it required trained psychologists to deliver these sessions, and those were lengthy sessions. It's a lot of time. Can we figure out smaller sessions over time delivered by clinic nurses, social workers, APNs, as a component of patient education that occurs over time during their work with us in the clinic? And how would that look like in terms of treatment outcomes versus who did not get it? So something which is feasible in our clinic. That's what I'm looking at.
Thank you. Shaila, how about for you? What would you like to see happen?
I would love to see insurance companies cover a kind of a program that a patient would come in to a pain clinic, they would get the medical evaluation, but as part of that, they would get the psychological evaluation and then the co-current treatment. So they would go through medication management, injections, or interventional procedures, but then also really working with the power of the mind through, maybe the patient would choose whether it's mindfulness or cognitive behavioral therapy. And that would just be standard course of treatment.
Which the research indicates. So thank you for that. And Alexandra, how about for you? What are some things you might like to see stemming from this research?
There are so many. One is We have an ocean of data, and this is because our participants were generous providing those data, and I do not want to see them just sitting the data and not put into good use. So that's one thing. Then how can we develop shorter interventions? Because I think we have already some quite a bit of information that could help us identify those key ingredients from each intervention. And maybe we can reduce the 16 hours plus 30 minutes per day, ideally, of practice at home throughout the study. Maybe we can shorten that to make it more accessible to both providers, but also to patients. Especially when one has severe pain, it's really hard to stay still for some period of time, like longer 2 hour session, that's a long time. The encouraging thing that was forced upon us by the pandemic was we switched everything to an online delivery. And this has not been done kind of before. Like there were no studies looking at the full 16 hours in person versus full 16 hours done remotely. And we have shown that our study shows, and this paper documents, there are no differences in outcomes, which means however people can do it, they should try to do it. We haven't tested completely asynchronous, like app-based delivery, but there's no reason to think it wouldn't work. And if that's what's available, again, it's great to have good instrument, a good teacher, a lot of practice, but one can try to self-manage and self-teach certain skills as well. Looking at cost, the benefit or economic analysis would be fantastic. But another area, we have a unique opportunity to potentially reach back to our participants and see who is still practicing. And if people keep practicing for so long, now it'll be years. Our first participant was enrolled in July 2017. So we are already 8 years out, essentially. So by the time we have the study, it might be 10 years out. Who is still practicing? Because if people are practicing so many years later, it means it's really doing something. Like nobody would keep doing those practices if they don't help. And those for whom it's helpful, well, what does it do? Like, what is the difference between people who actually continue on versus those who started then stopped versus those who never started? Because there was a group of people who signed up for the study, but then they never started the intervention, either one of those interventions. And last, I would like to mention there are 3 of us here online, but this was a large team across 4 sites. So we are representing here 2 sites, Penn State and University of Wisconsin in Madison. Bruce Barrett, who you know, at UW at the Department of Family Medicine and Community Health, has been one of the co-PIs. So instrumental to make it happen. But then Rob Edwards at Brigham and Women's Hospital, who was and Bob Jamieson there as well, who were the CBT gurus, plus Eric Garland at that time at the University of Utah, whose work in mindfulness is well known and recognized. So big thanks to the entire team and all the staff and personnel and investigators. This was a large effort.
Yeah, and I'm particularly interested as things unfold, particularly with a longitudinal analysis of if people are continuing, why are they continuing? What does that look like? Are they just listening to the same recording again and again? Is it silent? Are they doing different practices? Are they taking classes?
Exactly.
All of that. Who by? Is it a trained teacher? Is it not? What is all of that?
Wouldn't that be useful to know? It would.
Useful. Yep.
Now, the caveat is we need funding for it. This is beyond the original study. So we are on the lookout for many sources and completely open to suggestions.
Yeah. And hopefully things like this will raise the awareness of the need for that because of the way it can impact people who are suffering. Yep. And not just with chronic pain, but with a wide variety of different kinds of ailments that would be running into physical and mental.
Yep.
Well, thank you all very much. And for those of you who are watching or listening, there will be links to the pages for each of our guests today, as well as the study that we've been talking about. I hope you will all return to talk more about the work that you're doing. Our guest today, Shyla, thank you so much for being here.
Thanks for having me.
Nalini, thank you so much for joining us as well.
Thank you so much. I enjoyed being here.
And Alexandra, thank you for taking the role as lead author on this study and doing this work.
Thank you for having us.
Thank you so much to our guests today and to you for watching the podcast and our conversation. Please do subscribe to the podcast when you get a chance. It's just a button push and it helps other people to find it. Remember, every moment you have a choice. Make it the best you can. I'll see you next time on Mindfulness Voyage.